Dr. Mohit Arora, orthopedic surgeon. Today I will be demonstrating in this video the technique of total knee replacement on a dry bone model. So the side support should be at the level of tourniquet. The bolster should be placed in such a position that both knee flexion of 90 degree and 110 degree is possible. So anterior knee approach used, incision given. Try to avoid giving incision over the tibial tuberosity. Now superficial dissection. Take skin, fat and superficial fascia in a same layer to preserve the vascularity. Then deep dissection, there are three approaches: medial parapatellar, mid-vastus and sub-vastus. When you extend the incision distally, take a 1 mm patellar tendon sleeve for better closure. Now we move over in a clockwise fashion for the soft tissue dissection. So what we do is we take out the medial periosteal sleeve subperiostally till we reach the equator. We take out the tibial osteophytes, we rotate the tibia externally, we take out the medial meniscus, then we move over to the medial femoral side, we take out the osteophytes, we clear the anterior femoral surface, and then we take out the lateral femoral osteophytes. Then we come to the patella, we take out patellar osteophytes, we do patellar denervation at the same time. Then we move over to the lateral tibial side, where we internally rotate the tibia and dissect the lateral meniscus. Now we move over to the femoral notch, where we take out the ACL, we preserve the PCL in case we are doing a CR knee, and we sacrifice the PCL in case we are doing a PS knee. Now we dislocate the tibia. So after this dissection, I am putting the tibial zig. So this zig should be completely into the bone, it should be at the middle of the tibial spine. So the zig should be parallel to the shin of the tibia, okay, and distally it should be at the center of the angle. We can control the varus and valgus angle through that. The slope can be adjusted through that, and the length of the tibial cut that we need can be adjusted by that. Thank you. The length of the proximal tibial cut, I have taken a stylus on the medial side, so it should be 2 mm of cut on the medial side, or (9 mm) cut from the healthier lateral side in a varus knee. Now after confirming the position in all three planes, we put the pins. So after putting the pin, so now we put the capture in, and we take angel wing. Now we check the cuts with the angel wing. So we make an entry point which is usually 1 cm anterior and medial to the PCL insertion, or you can take the reference of a trans epicondylar axis and the anterior midline. So what you do is you put your left hand over the distal femoral shaft to feel for the direction of the bone, and then you go completely into the femoral canal. Now we insert the femoral zig. 5-degree valgus on the left side, that has to be confirmed. Put this femoral zig. Now you fix this by putting the pins. One oblique pin. So you now take this out. Take this also out. Put the capture in. Check the cut with the angel wing, so it should go freely into the intercondylar notch. So we have now taken the distal cut. Now we are going to remove the oblique pin. Take the pig out. So now we measure the extension gap at this time. Now if there is any fixed flexion deformity, then we can increase the distal femoral cut. Here we see the extension itself. The extensor space is perfect rectangle. Take the pins out. Now we have to take the size. We have to take the femoral size. Now this should be perfectly abutting the posterior femoral condyles, and its surface should be flushed with the distal femoral surface. Cut. Now we have to take the size from the lateral side. Now the anterior osteophytes from the lateral femoral and the anterior surface should be cleared for us to measure the femoral size in a better way. So the size is coming out to be exact 5. So if you put your angel wing into the size 5 slot, you will see from the side, that there is no notching. So that's another way to assess the size of the femur. So take the pins out. Now that's the 4-in-1 zig, size 5. So that's the anterior end, that's the posterior end. Now we fix them with the pin. So we check again for any notching, which is not there. Now we so you see the grand piano sign here. that's the anterior chamfer cut. I'm going to take the posterior cut. Now I'm going to take the posterior chamfer cut. So you have to protect the soft tissues on the medial and the lateral side when you're taking all these cuts. So now my cuts are complete. I'm going to take the pins out. So I take the 4-in-1 jig out. You can see the cuts. For the checking of flexion gap. That's for checking extension gap. So both of them should be balanced. Yeah. So what I'm going to do is I'm going to go try. This implant is perfectly sitting now. For this is a cruciate retaining femoral implant. However, we are going to cut the notch now, so we will need a different femoral implant. So that's the instrument for cutting the notch, and it should sit freely. That's for the notch cut. Then for the So you see now we have cut the notch. We're going to fill this cavity with the bone plug. So you see now the implant is perfectly sitting over the femur. So we are going to put the tibial implant hammer. Okay. So I'm putting a femoral implant now. Hammer. That's it. Now I'm going to put the take out this. I'm going to put poly over there. So that's it. You check for the extension, check for the flexion. Thank you so much for watching the video.